and then delivery can be later on go up to the term. So this is the various data of doing the procedures in 3-4 year data for doing the various procedures at our center for chromosomal disorders and for thalassemia, Duchenne muscular dystrophy, SMA, and that this family history is present into the family. So we take the sample from the fetus and we decide that baby is normal or not. And this is the data for fetal reductions. Sometime in IVF pregnancy, multiple fetuses comes into the womb. So we reduce these fetuses to number up to the 2 and sometime up to the 1. Now we have lab here, so I call Dr. Aditi or I invite her to brief about the lab work.
Thank you, Rekha ma'am. Good morning to all, respected patrons, senior faculty, teachers, dear friends, colleagues and students. I take care of the genetic lab, which is Advanced Center for Medical Genetics, and today I'm going to talk about the genetic tests that we are currently offering. So the genetic lab was inaugurated by our Honorable Emeritus Chairperson Dr. M.S. Swarup sir in the April of 2022. It is an advanced genetic diagnostic laboratory. It is the first and the only wet lab in the state of Rajasthan that caters both cytogenetics and molecular testing. It is a highly skilled and proficient manpower. We are located on the 4th floor of the hematology tower. So what test are we currently doing at the ACMG? We are performing chromosomal analysis, which is known as karyotyping, on multiple samples like blood, bone marrow, amniotic fluid, chorionic villi sampling, product of conception, and cord blood. We are also doing chromosomal breakage studies that comes under stress cytogenetics, which is commonly a test used for Fanconi anemia. Another test that we are offering is called fluorescence in situ hybridization, commonly known as FISH, for various cancers. We also do FISH for HER2, which is a diagnostic marker for breast cancer. FISH is also done on prenatal samples to rule out for common aneuploidies. Coming to the molecular genetic testing, we are doing PCRs for beta thalassemia, Duchenne muscular dystrophy, and Y chromosome microdeletion. The future plan is to upgrade on our technology by having NGS and microarray machines soon at our hospital. These are a few pictures of the lab and also the karyotyping and FISH analysis microscope. We are currently a team of 5 that takes care of the overall working and functioning of the laboratory. Thank you.
Thank you, Dr. Aditi. So I will call Dr. Diki, Neurology Resident, to present the clinical aspect of the case.
A very good morning to respected Emeritus Chairperson Sir, senior faculty members and colleagues. I'll be presenting the clinical aspect of the case today. A 30-year-old lady, right-handed, an NRI, residing in Dubai, a graduate, and a beautician by profession, presented to us with chief complaints of pain in her left thigh for past 1 year, that is since February 2023. The patient was well till a year back when she had a fall. She was in a marriage party and while sitting down, somebody mischievously pulled the chair from behind, so she landed on the floor. And since then, she was having persistent pain in her left thigh. Initially, there were some mild bruises which settled down. Initially, the pain was a sharp pain, and by the time she presented to us, it was a dull pain, a localized pain with no radiation and no aggravating or relieving factor. There was no history of any radicular pain, no history of any numbness, tingling, no history of any limb weakness, no history of any bladder wall incontinence, no history of any drugs or toxin exposure, and no history of any rash, oral ulcers, or joint pains. Now for this pain, initially she took over-the-counter medication in the form of painkillers and all. It did subside to some extent, but it was still persistent. So she visited doctors there in Dubai, where she was asked to do some investigations and even imaging studies was done in the form of X-ray, and since she had a fall, MRI lumbosacral spine was also done, and which was normal. So since she continued to complain of pain and her investigations were normal, she was even asked to visit a psychiatrist. So she did visit one, but she was uncomfortable in taking treatment for it. Then in the month of January 2024, that is almost 8 months later, since she was having continuous dull pain, she was again re-evaluated in Dubai, where blood investigations were done, and there her serum creatinine phosphokinase was found to be in the level of 3,828 unit per liter. The normal range being 0 to 145. So that was almost 20 to 30 times increased. So the doctors there asked her to get it repeated 2 weeks later. And the report 2 weeks later was 4,329. So it was further increased. So then she was given symptomatic treatment for it in the form of NSAIDs and gabapentin, and she was advised some more further investigation. Now our patient was fed up of being evaluated there for almost a year with no diagnosis in Dubai. So she wanted to come back to her hometown Jaipur and get evaluated here. So she visited us in the month of February 2024 with the complaint. Her past history was not significant. She was married with normal bladder bowel habits. Family history was not significant, or her menstrual history was normal. So based on the history, to summarize, we have a 30-year-old lady with pain in her left thigh that was preceded by a fall and an increasing creatinine phosphokinase level in the range of 4,000. So what could be the probable diagnosis? So CPK is an enzyme which is found in skeletal muscles, it can be found in brain, it can be found in cardiac muscles also. So we have two different units of it, M and B. So MM is from the muscles, B is from the brain, and MB is from the cardiac. So following any injury to the muscle, we may have increased CPK level. And then if in cardiac myocardial infarction and also we'll have the MB raised. In any stroke and all also if we see, we'll have it raised. Now in the muscle, there may be many reasons for it. It may be myositis, it may be toxins related. Following a strenuous exercise also it may be increased. Following any injections also it may get increased. As we all know, creatinine phosphokinase is an enzyme which may be present in skeletal muscles, cardiac and brain, as we said. And in a normal individual, it usually comes exclusively from the skeletal muscle. So, based on just the history, we went ahead.
Do we know whether CPK was a part of a routine blood panel, or was it done specifically that somebody suspected a muscular disorder?
So, according to the history that she gave us, it was done as a routine panel there in Dubai, sir.
It's an incidental trial.
Right, sir. So, based on the history, we went ahead with a very broad differential, muscle pain with raised creatinine kinase level. Our first differential was inflammatory myopathies like polymyositis, dermatomyositis. The points in favor was pain was there and an increased CPK level in the range of 1,000, which was almost 30 times more. Now, there was no complaint of any weakness, there were no rashes, and it was a very localized pain which was against our diagnosis. Metabolic myopathies like glycogen storage disorders, mitochondrial myopathy can also present with raised CPK and pain. But like the word metabolism, it is related to metabolism. So here we'll have episodic kind of weakness, episodic pain. Here there was no relation to any exertion or no fluctuation or episodic. So third differential was a drug-related myopathies. Point in favor was even drug-related myopathies like statins and all can cause drug-related myopathies. And here too we may have pain and raised CPK, but we did not get any significant drug history in our patient. Now myositis ossificans, it's a condition where following a trauma to the skeletal muscle.
Which statin you think is more responsible for the increased CPK or increase in muscle pain?
So atorvastatins?
Which one? Atova, Rosuva, or
Atorvastatins.
No, it is. I think cardiovascular. Every.
And atorva even rosuvastatin in higher doses can cause the myalgia, and even in few patients if they are having this HMG coenzyme related this myositis, so sometimes they can have the necrotizing myositis and that can be fatal. And but it usually happens with a very high doses.
So myositis ossificans was also kept as one as a differential. Now it is a condition where in the skeletal muscle, if there is an injury, sometimes what happens is the inflammatory cytokines stimulates the endothelial cells of blood vessel to transform into other cell lines, leading to formation of bone in soft tissue. Here there was a long history of pain. She was evaluated outside with no diagnosis. So that could also be one of the differential. Fibromyalgia, long history of pain, evaluated with no diagnosis. Against it was in fibromyalgia, there's usually a diffuse pain. Here we had a very localized pain. And our final differential was muscle dystrophy since pain was there. And a CPK more than 20 to 30 times, we think about muscle dystrophy as well. The points not favoring it was there was no weakness and there was no family history. On general examination, she was a normal build lady. There was no rash, no skeletal deformities, and her vitals were normal. Local examination, no raised temperature, no tenderness, no swelling or any discoloration. Neurological examinations, higher mental functions were normal, cranial nerves were intact. Now coming to motor examination, the bulk and the tone were normal in both upper limb and lower limb. Now for the power examination, we use MRC grading, that is the Medical Research Council grading. We have 0 to 5. 0 means no movement, 1 means some flicker or contraction is there, 2 means movement with gravity eliminated, 3 means against gravity, 4 means against gravity and against resistance. Now this can be 4 minus 4 plus, 4 plus with some moderate resistance, 4 minus with very less resistance, and 5 is normal. In upper limb, the power was normal. Now when we examined her lower limb, the positive finding that we got was, in a hip extensor, the power was 4 plus by 5. Now this was a very subtle weakness that we got. So we asked our patient to sit down on the floor and get up to see whether she is able to do so. And then what we noticed was, when we asked her to stand from a squatting position on the floor, she bent forward, stood up taking the support of the floor. Now this was a bit unusual for a fit lady of a 30-year-old. So we asked her why she's taking the support of the floor. So she tried it again and again she had to take the support. And then on asking her, she told us that she had never really realized that she was standing this way. And to think about it, she's been doing it since childhood. And she did not give us permission for a video, sir. So this was a positive finding that we got in examination, a very subtle weakness in the hip extensors and history suggestive of it since being childhood. Other motor examination, her deep tendon reflexes and superficial reflexes were normal. Her sensory examinations were normal. There were no cerebellar and no meningeal signs. Other systemic examination like cardiovascular system, respiratory system and per abdomen examinations were normal. So since we have got some weakness and some history suggesting that it was since childhood, so we wanted to revisit our history, that maybe we have missed out something. So on repeatedly asking her and asking her direct questions, she revealed to us that yes, in her mother, who was 50 years old now, there was some history of change of gait in her mother in her 4th decade. Although she has started walking with slight swaying of the waist, that they have noticed. And there was also history of suggestive of proximal muscle weakness in the mother. Like now her mother, when she had to sit up from a squatting position, somebody needed to hold her. And on standing from chair or walking upstairs, she needed to hold on to something. And they had attributed
to tell all of you that if you are not doing regular sit-ups, then even the normal people may find it difficult to stand up from the floor. So if you want to do your fitness test, kindly start rising without support. You will come to know how much fit you are.
So, and sir, they had attributed it to her age, so they had not really evaluated it for it. So now, after examining the patient, we had got, to summarize, we had a lady with pain in the thigh. Now there was some weakness in her hip extensors. And historical wise, she says it's there since childhood. The CPK level was on the increasing titer, and there was a positive family history in the form of mother having similar complaints. So with this, we did some basic lab investigations. Her CBC, RFT and electrolytes were normal. Her LFT showed SGOT, SGPT in the range of 55 and 74. Vitamin B12, thyroid, vitamin D, HbA1c and RA factors were also normal. Now we repeated our serum CPK level again here in our lab. It was 6,795. The initial level being 3,800 and 4,300. So it was in a increasing titer. So now revisiting our differential. Now that time we just had pain, and pain was there with increased CPK. Now we had weakness and a positive family history and since childhood. So our first differential inflammatory myopathy seems a bit unlikely, taking into account the family history that we got. Metabolic myopathy, family history may be there, but since childhood with no weakness as such, so this also becomes unlikely. Drug-related myopathy will be no, there will not be any family history in this, no drug exposure, so this also becomes unlikely. Fibromyalgia, as we all know, is a diagnosis of exclusion. Here we have many hints pointing us towards a diagnosis, so this also becomes unlikely. Myositis ossification will also not have a family history, but since there was a history of trauma which led to all this, so we still wanted to rule this out. And along with this, our next differential was muscle dystrophy. So with this, we wanted to evaluate her. So now what should be the next investigation?
Why did you exclude metabolic? It could be present since childhood and there could be a family history.
Yes, sir. But sir, metabolic myopathy since childhood with no weakness, by now the weakness should have been profound. With no progression and a very indolent course of the disease led us to exclude this, sir.
Metabolic में typical aggression के साथ में they are having the worsening of the weakness, and sometimes with excessive derivation they may have the episode of abnormality. Sometimes they notice the brown during increase. For the last 20 years, she doesn't have such a history. It seems to be less than.
So coming to our next investigation, we had, or we could go for a neurophysiological testing like electromyography or a muscle biopsy, or radiological scanning in the form of MRI, pelvis and thigh. Now since we still had to rule out myositis ossifications, which is diagnosed on the basis of scanning, so we needed to do this. And dystrophies have selective and patterned involvement of muscle, which are suggestive of specific dystrophy. And our patient did not want to undergo any invasive testing, so we decided to go for radiological scanning in the form of MRI. I now invite Dr. Pooja to tell us about the MRI findings.
Good morning, respected teachers, seniors, and my dear colleagues. I will be discussing the MRI findings of this case. The patient was referred to us for MRI pelvis and bilateral thigh with suspicion of myositis ossificans and muscular dystrophy. In MRI for muscle assessment, we generally look for muscle atrophy, that is loss of muscle bulk, fatty infiltration which appears as increased signal intensities on T1 sequences, and stir hyperintensities which are suggestive of edema or inflammation. In axial T1 weighted image of our patient, we can see fatty infiltration of gluteus medius and gluteus maximus muscle on right side and gluteus minimus muscle on left side, as compared to the normal image which shows normal muscle bulk and homogeneously iso-intense muscle fibers. In axial stir sequence, we can see patchy hyperintensities suggestive of edema in right gluteus maximus and medius muscle. In the axial sequences of upper thigh, stir hyperintensities and fatty infiltration are seen in multiple thigh muscles bilaterally with a relative sparing of semitendinosus and gracilis muscle. As no focal lesion suggestive of myositis ossificans is seen, this was ruled out. All the other findings of fatty infiltration, atrophy and edema involving specific group of muscles favors the diagnosis of muscular dystrophy. So, to further evaluate, we did screening MRI of other group of muscles such as calf and shoulder. Screening images of calf shows fatty infiltration of bilateral soleus and gastrocnemius with sparing of tibialis posterior as seen on left side. On screening images of shoulder, we can see fatty infiltration involving right subscapularis and left deltoid muscle with reduced muscle bulk. Here is a table to summarize the radiological findings. The muscles which were predominantly involved showing atrophy, fatty infiltration and edema are gluteus maximus and medius on right side and gluteus minimus on left side with relative sparing of iliopsoas muscles. In the thigh, adductor and vastae group of muscles are involved with sparing of semitendinosus, sartorius and gracilis. Other muscles involved are gastrocnemius and soleus with spared tibialis posterior. In shoulder, subscapularis and deltoid shows involvement with sparing of trapezius and supraspinatus. This pattern of muscle involvement is similar to findings seen in Duchenne's muscular dystrophy. Although Duchenne's muscular dystrophy is an X-linked recessive disorder seen in males and shows symmetrical involvement, which is contrary to our case. But according to literature, rarely female carriers can show asymmetric involvement of similar group of muscles. So on this basis, we kept it as one of the differential diagnoses. Other differentials on the basis of asymmetrical involvement are as follows. In limb-girdle muscular dystrophy 2B, gluteus minimus is predominantly involved, so it can be a closed differential. Limb-girdle muscular dystrophy 2L predominantly involves semitendinosis, which is not seen in our case. Hence, it is a less likely diagnosis. In facioscapulohumeral disease, there is involvement of trapezius and supraspinatus, which was paired in our case. Hence, this is also less likely. So, we left with these two differentials and we advise further evaluation. Thank you. I would now call Dr. Diki to carry forward the case.
Thank you, Dr. Pooja. Now, after getting the MRI report that we gave us, so visiting our differential, we were left with two differentials, myositis ossifications and muscle dystrophy. Now, with the report, we can safely rule out myositis ossificans. So, we have muscle dystrophy as our diagnosis. And according to the MRI report that they gave us and clinically, she fitted into limb-girdle muscle dystrophy. But since MRI findings were also suggestive of Duchenne's, so we kept two differential, limb-girdle muscle dystrophy or Duchenne muscular dystrophy. Now we needed to go ahead with genetic testing for this. So we referred our case to the Department of Genetic Medicine for their expert opinion. Now I invite ma'am to kindly take us through the case.
So, to summarize, this was the case which was referred to us for further evaluation. So, in this, actually genetic reports are not very simple like blood reports. So interpretation needs many things. So we will discuss one by one how we reach the final diagnosis. So you have to keep some patience for that. So this was a 30-year-old lady with pain in thigh and muscle weakness and raised CPK, and she had positive family history. In neurological examination, she had needs some support from standing from sitting position, and in extensor muscle of thigh power was around 4/5, and in MRI they suggestive of either it's a limb-girdle muscular dystrophy or Duchenne. So it is a kind of muscle dystrophy. So we need to evaluate about this. So first a patient when comes to us, then we make a clinical diagnosis at ours. So just it was a raised CPK. So when a patient comes to genetic OPD with raised CPK, then few of the muscle dystrophies which are common in this case, like Duchenne muscular dystrophy is associated with very raised CPK, and few of the limb-girdle muscular dystrophy are also associated with raised CPK. Why these muscle dystrophies are associated with raised CPK? Because these proteins, like this dystrophin protein, is synthesized by a DMD gene, dystrophin gene, and these are various LGMD proteins. These are very closely associated with the muscle membrane, and when there are abnormal protein product or gene defect, then these proteins are not synthesized and their structural membrane defect are there. So CPK is released from muscles. So in few of these muscle dystrophies, CPK is very high. So for this, we made this clinical diagnosis that this could be the cause of raised CPK in this female. So clinical suspicion H was LGMD and second was DMD. Actually, in general scenario, DMD is an X-linked recessive disorder. We looked at males are affected with DMD. So we keep this diagnosis little bit back and we keep on working LGMD. So when a patient comes to us for testing, then we have two group of tests for the patient as a geneticist. One is for chromosomal disorders, second for single gene disorders. So first we have to characterize the phenotype of patient, whether it is fitting into the chromosomal disorder or single gene disorder. Chromosomal disorder you have heard like Down syndrome, Edwards syndrome, Turner syndrome, in which numerical or structural abnormality of these chromosomes. Then we suspect the chromosomal disorder, then we order the karyotype and microarray. But here what was the case? Here was the case that some muscle protein was defective. So muscle proteins are synthesized by genes, and these genes are part of these chromosomes. So each chromosome has multiple genes. Like chromosome 1 is the longest chromosome. It has highest number of genes, like 3000 genes are present on chromosome 1. Chromosome Y is smallest number of chromosomes, so it has smallest number of genes, like 70 to 200 genes are only available on chromosome 7. So we need to test for these particular genes as the gene is defective. So symptoms of single gene disorder are also organ specific. Like if beta globin gene is defective and hemoglobin is not synthesized, then patient will present with anemia and thalassemia will be the diagnosis. So symptoms of gene will be organ specific. Like in our case, neuromuscular phenotype is there, so gene of the neuromuscular system is defective. So for single gene disorder, there are battery of tests with us. One test is Sanger sequencing of particular gene. Like I am thinking of LGMD, so I may ask to the lab that you do the sequencing of that particular gene. But sequencing is available only for few genes like thalassemia, VHL, because these are very small genes. So this Sanger sequencing is not available for all genes. Nowadays, what the lab do, that they sequence all of the genes in one go, and then the data is read by the bioinformatician, and they read the data according to the phenotype of the patient. Like they have generated data from all of the genes. Then if we clinician given the phenotype that you search for genes of muscle dystrophy, then they search the data for muscle dystrophy gene and they give us the mutation in finally muscle dystrophy gene. So most common test we offer here is whole exome sequencing. In whole exome sequencing, all of the coding regions of our genome are sequenced in one go. Around 20,000 genes, exomes are sequenced in whole exome sequencing. So this test was offered to the patient. So this was a report of her whole exome sequencing. So in whole exome sequencing, we find that she had mutation in TITIN gene. This TITIN gene is responsible for limb girdle muscular dystrophy type 10. She had two variants. It means it was an autosomal recessive disorder. Both of the alleles are defective. So the disease is autosomal recessive and limb girdle muscular dystrophy type 10. The lab given this, but what was not in fitting, that variant classification was variant of uncertain significance, because this classification helps us to understand that by this mutation whether that gene gets dysfunctional or not. Like if these variants are either pathogenic, classification is either pathogenic or either likely pathogenic. It means by this mutation that gene gets dysfunctional. It means lab had sufficient evidence that if this mutation occurs in this gene, then this gene gets dysfunctional and phenotype occur. So if variant classification is pathogenic and likely pathogenic, then we are convinced that this is the cause of her illness. But here classification was variant of uncertain significance. So sufficient evidence were not there whether it is the cause of her illness. So we were not attributing this report to her illness. So one reason was this, that we were not attributing this report, and second reason was her family history. Like you can understand that in autosomal recessive disorders, what happened? In autosomal recessive disorders, they present in only one SNP. Only one SNP is affected. Parents are normal. Parents are carrier, and their offsprings may be affected in autosomal recessive disorder. So LGMD10 is an autosomal recessive disorder. So her brother and sister should be affected, not the mother. So inheritance pattern was also not suggestive of this diagnosis. So this stuck for this thing also, because family history was not suggestive and variant classification was not suggestive. So according to us, limb girdle muscular dystrophy was a less likely possibility in this case. Still we kept a small possibility because we will work again, then we will come again to the diagnosis. Then another clue in MRI was that muscle pattern suggestive of Duchenne muscular dystrophy. So we went on testing for Duchenne muscular dystrophy. So audience may ask the question that whole exome sequencing sequences all of the exons of all of the gene, and dystrophin is also a single gene. So WES cannot exclude the DMD in the patient, because this is also a single gene disorder. So this report should exclude the DMD also. But no, DMD has unique kinds of mutation in the gene. In DMD, there is deletion of the whole of the exons. Like DMD is large gene. 79 exons are there. And what is the mechanism of mutation? 2-3 more exons are deleted in DMD gene. So that is the region of dysfunction of dystrophin gene. So large deletions are there, and these cannot be picked up in WES with very surety. So for DMD, if we are suspecting DMD, we need to advise DMD MLPA, multiplex ligation dependent probe amplification, because this detects the copy number variation, that exon deletion or duplication is there or not. So in this patient we offer the DMD-MLPA. So in DMD-MLPA we find that she had deletion of exon 8 to 45. These number of exons were deleted in her, but they give that heterozygous deletion. Why heterozygous? Because she has 2 X chromosomes. She is a female. So one X is normal, one X has mutation. So heterozygous deletion. So lab said that she might be a carrier of the DMD. But we are finding that she has symptoms, she has ACPK. So we need to evaluate the patient further. So we were still stuck in the dilemma, because when we were looking both of our diagnosis of the lab, LGMD we keep it less likely because inheritance was not suggestive, variant classification was not suggestive. In DMD, MRI pattern was suggestive, but mainly male child are affected and females are generally asymptomatic carriers. So this was also not a much evidence, so we needed more evidence to classify her as a DMD cause of her illness. So we deeply went into the family history. In history they said that mother is now having some symptoms. So we called the mother in neurology OPD, examined her. So mother was having lumbar lordosis. She had gait abnormality, waddling gait was there. And on examination she had proximal muscle weakness. So we advised this DMD mutation analysis of mother also. And when we advise this DMD mutation analysis of mother, then we find that mother was also having the same mutation of DMD. She was also carrier for the DMD. So now what is the thing that then we reviewed the literature and we find that some of the DMD carriers may manifest with symptoms. So now we were nearly conclude our diagnosis that one favoring was MRI pattern and second that both mother and daughter had mutation in DMD gene. Both are symptomatic, so they are manifesting carrier of dystrophinopathy. So then we reviewed the literature that it is an X-linked recessive disorder. So why it presented in a female? Dystrophinopathy, why it presented in a female? So one of the answer is skewed X inactivation. What is skewed X inactivation? Male had 1X and 1Y and female has 2X. Male is normal with 1X, body functions are normal with 1X. So female has 2X. So to maintain the gene balance in females, 1X gets silent. We called it as random X chromosome lionization. 1X chromosome get inactivated in female cell and only 1X chromosome is active. But in all the females, this X chromosome inactivation is random. In few cells, maternal X chromosome is active. In few cells, paternal X chromosome is active. So this is random X chromosome lionization. Functions only 1X chromosome, but another chromosome is inactive. But in few females, there is skewed X inactivation. It means 1X preferentially get inactivated. Like in our female, we may think that normal X get inactivated in most of the cells and abnormal X get activated. Like in this family, blue color is showing the DMD gene mutation. So in this daughter, most of the cell have this X chromosome active, that is having mutation. So skewed X inactivation is one explanation. Second explanation, when the female is Turner syndrome, only one X is there. So if it has disease mutation, then it will present with the disease. Third, when X chromosome get translocated with the autosome. Autosomes, it means 1 to 22 number of chromosomes. These are autosomes. So autosomes are very important for our body function. So if one of the autosome is translocated with X, that autosome need to be active, so that X need to be active. So if mutation is on that X, then it will be active. So in those cases also patient may present, and sometimes if gonadal dysgenesis 46XY female, then there may be the presentation of this phenotype. But in our case, there is generation passed on through generation, mother and daughter are there. So we kept the skewed X inactivation is the most likely possibility. So final diagnosis for our case is manifesting carrier of Duchenne muscular dystrophy. So now coming on to the phenotype, so we search that females are generally asymptomatic carrier, but in few females there may be classical dystrophinopathy. And what are the phenotype of classical dystrophinopathy? You have heard of Duchenne muscular dystrophy and Baker's muscular dystrophy. Generally males with Duchenne and Baker's present in neurology OPD and other OPDs also. So Duchenne muscular dystrophy is very severe, present at less than 10 years, wheelchair bound by 13 years, and baby expires by 20s to 30s. While the Baker's muscular dystrophy is little bit less severe, they present in teenage or adolescence, then they may be wheelchair bound, and then they may be alive up to 60s. So this is a milder phenotype, and our patient had little bit milder phenotype. Then we more reviewed the literature, and then we found that around 20% of female carriers may present with symptoms of muscle weakness, few may present with myalgia or cramps. So our patient was fitting into this 20% group. So now what is the treatment? If we have diagnosed a case, we have any treatment? So few treatments are tried, gene therapy is tried, few anti-inflammatory agents, corticosteroids are given, but these are given only to severe childhood onset Duchenne muscular dystrophy. In this case, as in DMD, there is loss of complete dystrophin. So to replace a small amount of dystrophin, they give either gene therapy like Illividis. They FDA approved this gene therapy, and sometimes if mutation is present in exon 51 or exon 53, then exon skipping therapy is also available, so that there is read through either a small protein is formed, but at least few dystrophin protein is present in the tissues, then patient may function to some more years. So these therapies try to moderate the course of DMD, they try to convert the DMD into BMD. And this anti-inflammatory drug daflagercourt, this also reduces the inflammation into the tissues and try to reduce the wheelchair bound stage up to the 2 to 3 years. But however, disease course is not modified in daflagercourt therapy also. These are just experimental FDA approved therapy, but not up to the mark in Duchenne muscular dystrophy. But in our patient, these therapies are not needed. She have just raised CPK and mild pain into the thigh and subtle weakness. Even she didn't perceive that weakness. So just symptomatic management was offered for those symptoms. But yes, she is at risk of cardiomyopathy because DMD gene can cause cardiomyopathy in 20% of female carriers. So we offer her routine cardiac surveillance, echo once in a year, and prompt treatment for that. And we asked her that she should avoid botulinum toxin injections, succinylcholine inhalation and anesthetics because they may cause malignant hyperthermia in each patient. So apart from this, what was important for her? That was genetic counseling. Why genetic counseling was important for her? Because she was married for 5 years, and for first 3-4 years she didn't plan for the pregnancy. Now for 1 to 2 years she was planning, getting some kind of difficulties. So she plans her pregnancy. So this is the right time to counsel her. What is the risk of this mutation to passing her offspring? Like in this picture, this female is manifesting carrier or normal, but she has DMD mutation, and she will pass on this mutation to 50% of his or her sons, to his sons, and those sons will have DMD. So we educated her about this, that she had chance of 50% passing this mutation to her offspring, and 50% of boys will be affected. 50% of females either normal or either manifesting carrier, but these boys should be avoided. So we counseled her. Our patient was wise enough. So she asked me that I am passing this DMD to my offspring, whether there is any disease my husband can pass on to my offspring, or we both can pass on some other disease to our offspring. This was question of her to us. Then we said yes. There is a way that we can detect inherited disorder in your offspring, that you are at risk of passing or not passing. Like this is the Janam Patri, which we match before marriage. So this is the gene Patri. This should be matched before planning the baby. Not before the marriage, but before planning the baby. This is just gene Patri is the name given by commercial lab to popularize this test. This is not a standard name, but this is the name given by labs to popularize the test. Before planning baby, you may go for gene Patri. In this gene Patri, we go for gene Patri for her also. We did the carrier screening of both husband and wife, and in husband and wife we matched both. If both are positive or both are present, then we should avoid that disease in her offspring. We offer them CVS or amnio to avoid that baby. And in this gene Patri, we consider only the pathogenic and lightly pathogenic variants. If UUS are there, we will not consider for clinical testing. So we offer this gene Patri to her, and then she was very keen of having the baby. So we referred her to Department of Reproductive Medicine and Surgery for further management and counseling.
Thank you, ma'am.
Good morning, respected Emeritus Chairperson, sir, respected teachers, and my dear colleagues. My patient, Mrs. X, 30 years old female, she is a manifesting carrier of Duchenne's muscular dystrophy. She was referred to the Department of Reproductive Medicine and Surgery from the Department of Medical Genetics for preconception counseling and reproductive planning. The history has been described in details by the neurology department, so I'll just provide a concise overview. The patient has been married for the last 5 years and they have not been trying to actively conceive in the initial 4.5 years. It's only in the last 5 to 6 months that they started planning for a pregnancy. The patient is a nulli gravida and her menstrual cycles are regular. There is no significant past medical or surgical history in the patient. Her husband's history is also normal with no significant findings. Now coming to the reproductive options that we provided to the patient or the couple, we provided the patient that there are primary 3 options available to them. First is natural conception, second is in vitro fertilization, and the third is the alternative methods. So if the couple decides to go for a natural conception, they can go for a prenatal testing, which is done in the form of chorionic villus sampling, 11 to 13 weeks of gestation, and this chorionic villus sampling will determine the genetic status of the fetus. So if in chorionic villus sampling, if we find that the fetus is affected with Duchenne's muscular dystrophy gene, then the couple can go for medical termination of pregnancy. While if we find that the fetus is manifesting carrier of Duchenne's muscular dystrophy, like in our case, then we cannot advise medical termination of pregnancy in that case, because we have seen that the manifesting carriers of Duchenne's muscular dystrophy patients are not having severe symptoms. They are not having such severe symptoms that they are handicapped. So this is not an indication for medical termination of pregnancy. So after giving this option to the patient, they denied this option because they did not want to undergo chorionic villus sampling and medical termination of pregnancy. So the only 2 options left with the patient were in vitro fertilization and alternative methods. So if she goes for in vitro fertilization with pre-implantation genetic testing, we can identify the unaffected embryos and then transfer the unaffected embryos to the uterus. Alternative methods are the last resorts when all the other methods fail. They include donor oocytes and adoption. So after explaining all these options to the couple, they decided to go for in vitro fertilization with pre-implantation genetic testing. So what exactly is pre-implantation genetic testing? It's a technique used in IVF wherein we test the pre-implantation stage embryos or oocytes for any inheritable genetic defects so as to prevent its transmission to the offspring. So in this case, we need to decide that what type of pre-implantation genetic we will be doing. So basically there are 3 types of pre-implantation genetic testing. First is pre-implantation genetic testing A. A stands for aneuploidy. It detects whether there are correct number of chromosomes or not. Second is pre-implantation genetic testing mosaic. It detects whether there are any single gene disorders or not. And the third one is pre-implantation genetic testing SR. SR stands for structural rearrangement. It detects if there is any chromosome rearrangement. So in our case, particularly because the patient is a manifesting carrier of Duchenne's muscular dystrophy and it's a single gene disorder, so we will be going for PGT-M. So the plan of the patient is that the patient is under the follow-up of the Department of Reproductive Medicine currently. Further evaluation of the couple is being done and we will be planning in vitro fertilization with pre-implantation genetic testing and then transfer the unaffected embryos to the uterus. Now this is a small video demonstration of the embryo biopsy that we usually do in our labs. We will be planning this biopsy for this patient also. This is a crucial step. This is a crucial step in the pre-implantation genetic testing. Here this is a day 5 embryo and as we can see with the pipette we are extracting the trophectodermal cells and these cells will be subjected to the genetic analysis for assessing whether the embryo is affected or not. And then finally we will transfer the unaffected embryo to the uterus of the patient. Now I would like to call Rekha ma'am again to continue the case.
So now this is the end. So first of all, why we choose this case, because this case does not have many intervention. This just has diagnostic dilemma and just we reach a diagnosis and we help her for genetic counseling. But why we choose this case? Because this case is exception to the general principles of X-linked recessive disorders. Like you will see that this is the X-linked pedigree, only males are affected. All of the clinicians identify that if in any pedigree only male affected, then you will see that this is the X-linked recessive pedigree. But in our case, what was happening here? Only females are affected and her mother was also very lucky that she passed on normal X chromosome to her son. Son was normal and female was manifesting carrier, and female also was lucky that before planning the pregnancy she get diagnosed with the DMD carrier. Now she can also avoid the baby affected with DMD. So these two things attracted us to discuss this case. And second important thing is diagnosis on subtle symptoms. So in this case very subtle symptoms were there, but there was a big hidden diagnosis in this case. Third thing, importance of family history in genetic disorders is very important. It guides us the inheritance patterns, it helps us to search the cause into the patient. And fourthly, MRI nowadays very helpful non-invasive method to differentiate among the various kind of muscle disorders, specific patterns. In this case, MRI guided us a lot for to reaching the differential diagnosis, and even become one of the evidence to us that we should think of that this is an X-linked recessive manifesting carrier, because MRI pattern was also suggestive of the same. So these two evidence come together and we think of that she is presenting with this only. And diagnosis obviously needs the multidisciplinary approach. In this case, every department has its importance, like neurology, radiology, and even reproductive medicine is very important for us, because now they will help her to get a baby with free of DMD. So now I close my case. So any questions from audience?